Thank you very much for the kind introduction. I'm really happy to be here today. Chemotherapy-induced neuropathy and the issues surrounding have been a part of my life for about the last 8 to 10 years since I graduated from fellowship. So I'm really delighted to be here today to chat with you about it. So today we're going to talk about what you need to know as a patient or provider and see if we can cover a lot of ground about chemotherapy-induced neuropathy. So my financial disclosures. So the goals of the talk today, I want to articulate, at the end of this talk, I'd like for any of the participants to be able to articulate the common presentations of CIPN, describe the clinical importance, recognize the diagnostic conundrums that arise with new neuropathy in cancer patients, and apply CIPN guidelines directly to patient care. And so the way that we're going to do that, we're going to try to cover a lot of ground. So we'll do some background. We'll talk about why you should care about chemotherapy-induced neuropathy. We'll review the common forms, talk about making a diagnosis, and this will pertain both to patients and providers. From a patient perspective, we can talk about how you recognize the symptoms in yourself, risk factors and prevention strategies for CIPN, what the therapeutic options are, and how to recognize when to access an expert. So I know that the audience today is made up of sort of a variety of people, oncologists, patients, loved ones, patient advocates. So I want to start out just with some sort of basic information about what neuropathy is and what chemotherapy-induced neuropathy is. So most of you probably know somebody who has neuropathy. The incidence of it increases over time with age. And there are many people in the United States that have diabetes who have neuropathy. So the word neuropathy just means nerve damage. So basically, when we're talking about neuropathy, we're talking about the nerves that start in the spinal cord and come out and descend down the limbs. And so you can see in the sort of diagram over here, it's just a diagram of what the nerves look like. And it's important to understand the kinds of nerves that we have, just to understand what happens with neuropathy. So these are the sensory receptors. So these are in your skin or in all of your tissues, and the information from your nerves comes in through these receptors. This is where the neuron lives, and then it comes into the spinal cord. Once it's in the spinal cord, it communicates with a variety of things, but then there are nerves that exit the spinal cord. They come out, and these are motor nerves. So this is how you control your muscles and how you use your strength. And so basically, for essentially most forms of neuropathy, it tends to be a length-dependent process. So it affects the fingers and the toes before it affects the other parts of the nerve. And there are exceptions to that, which we'll talk about today, but that's sort of one of the basic principles. And there are reasons for that, and it has to do with how damage occurs when people develop neuropathy or when there's toxins that affect the nerve. So if you think about this little cell body here being really close to the spinal cord, that's where the cell lives, and then it has this very long extension that extends all the way down your limb, for instance, into your toes. So as you can imagine, anything that affects that nerve or anything that poisons it or damages it at all, it makes it hard for the nerve to be able to send nutrients and signals all the way down the nerve to get to the toes. So when people develop neuropathy, usually it starts in their toes and their fingertips, and it can slowly work its way backwards. And the reason I'm telling you this is that for chemotherapy-induced neuropathy, most of it looks like this, but there are forms that can look another way as well. And so most of the time when people develop CIPN, it affects sensory nerves. And what that means is that people develop loss of sensation, issues with their balance, troubles with dexterity, or substantial amount of pain. If it affects the motor nerves, which really is the minority of people with chemotherapy-induced neuropathy, it can cause weakness, but that doesn't happen all that frequently. There are other types of nerves that can be affected. So it affects the autonomic nerves. Those are the nerves that supply a lot of the organs throughout the body. They can cause a variety of other symptoms, which we'll talk about later today. So other sort of basic principles for understanding chemotherapy-induced neuropathy, it's a toxic neuropathy, meaning it's coming from the toxin, which is chemotherapy. And in general, the more chemotherapy you give somebody, the worse the neuropathy is. There are a lot of caveats there, but that's sort of one of the basic principles. The other thing is that there's this strange phenomenon that happens with some of the chemotherapeutic agents called coasting, where people may or may not develop neuropathy during their course of chemo, but even after the chemo stops, in the 1 to 3 months afterwards, you can still develop some nerve symptoms that weren't there previously. But that is the minority of patients in which that happens. So one of the most important questions today is, chemo cures cancer. So why do we care about chemotherapy-induced neuropathy? Why do I have a 45-minute talk to discuss it today? So there are a lot of reasons, and something interesting has happened in the last 10 years or so. When I first came out of training, there are really not a lot of people interested in chemotherapy-induced neuropathy, or a lot of people doing research in this space. And there's been an explosion of research and collaboration between neurologists and oncologists in the last 10 years. And I think that has led to a new body of literature which really talks about the importance of chemotherapy-induced neuropathy and the effects that it has on people's lives. So the neuropathy itself really depends on the agent, but somewhere between 30 and 70% of people who are exposed to neurotoxic chemotherapy end up developing neuropathy. So it really is a large number of patients. And one of the things we know about it is it has a really important effects on quality of life. So there's research to show that the severity of people's neuropathy is actually directly related to their quality of life and interference with things like activities of daily living, depression, and sleep. And so the effects are multifactorial. So when people have part of their nervous system affected by symptoms like this, their body feels sort of less in their own control, which is something that happens with chemotherapy and its side effects to begin with. Oftentimes, if they lose sensation, they feel a little bit less safe because their balance is affected. This can have effects on how often people participate, go out in activities, and get out of their home. It can affect their ability to do things around the home, and subsequently affects the structure, what happens within the home. As you can see, there are all these effects that can build up and really make an important impact on quality of life. And certainly this isn't everybody. Many people have chemotherapy-induced neuropathy, which is quite mild, but there are more severe forms that really impact people's quality of life. So the next is that chemotherapy-induced neuropathy actually has a substantial cost to our healthcare system. So Crystal Pike did an interesting study a couple of years ago, which showed that if you took patients who had cancer and received chemotherapy and looked at those who did and did not develop chemotherapy-induced neuropathy, that the cost of care for them is about $15,000 a year different between those patients. And it's not because of the medications you use to treat the symptoms. It probably has to do with the complications that can occur of chemotherapy-induced neuropathy, like falls or visiting the emergency department, etc. But perhaps one of the most important reasons to talk about it is that it may have an impact on survival. And there is a lot of sort of disagreement in the literature about what this actually means, but I think it's important to talk about. So there was a study done by Ethan Bash a couple of years ago down at UNC, which looked at patients who were getting chemotherapy, and they used a system where they monitored the patient's symptoms and responded to them proactively using medications or other therapies to help reduce the side effects they were having from their chemotherapy. And what they noted was that they were able to reduce symptoms at the time, but if they followed patients for years down the road, there was actually a survival benefit. So the patients whose symptoms were better managed actually survived longer. And it's hard the way the study was done to figure out exactly what the mechanism for that is, but they posited that it was likely due to two things. The first is that they may be able to prevent some of the downstream consequences of the side effects, like of chemotherapy-induced neuropathy. But they also noted that in managing the symptoms, people were able to receive more chemotherapy because their symptoms were well tolerated and the side effects had less of a consequence on their daily life. So now we're going to talk a little bit about the different forms of chemotherapy-induced neuropathy, because different types of chemo cause different types of neuropathy. So if anybody wants to take a screenshot of this or take a picture on your phone, go ahead. We're going to talk about these in detail, but it's just a nice reference slide if you're curious about what causes what as a practitioner and how frequently. So for the taxanes, so paclitaxel and docetaxel. So these drugs are used mainly for breast, ovarian, non-small lung cancer, but it's also a variety of other things. The way that they work is they increase the stability of microtubules. So these really small tubules within a cell that allow it to organize its components and allow the cell to transport things back and forth. And so when you stabilize these, it creates problems because the cell can't reorganize in response to changes. And you can form these crystalline structures within the cells that interfere with the ability to transport things. So it affects their ability to send nutrients and et cetera all the way down the nerve to the end. What it typically results in is a chronic sensory neuropathy. So numbness, tingling, sometimes pain. And because of the sensory loss, patients can actually develop something called ataxia, where you can imagine if you're standing on your feet and the nerves in your feet are not telling your body where they are and where you are in space, you may wobble some and you may have difficulty with your balance. And that can be seen in the hands as well. That's called ataxia. And it's a little bit different than other forms of neuropathy like diabetes, because you can actually start to develop neuropathy in the hands and the feet at the same time. With people getting taxane infusions, there is an acute syndrome called paclitaxel acute pain syndrome. So this is a syndrome of acute myalgias or arthralgias, so muscle and joint pain that occurs usually within 1 to 3 days after getting an infusion and almost always resolves before the next infusion the following week. It seems to be more common with infusions that go at a high rate, probably related to higher peak drug levels in your serum. The pathophysiology, or the way that this works, is sort of poorly understood, but there are a number of chemotherapy-induced neuropathy experts who feel like this is probably a harbinger of the later development of neuropathy. So while it probably doesn't cause people to develop neuropathy down the road, it may be sort of a warning sign that people could develop neuropathy. That said, there are plenty of people who do develop paclitaxel acute pain syndrome and never go on to develop neuropathy later on. So the platins are used to treat a variety of cancers as well. So lung cancer, ovarian, bladder cancer, cervical and testicular cancers. So these are alkylating agents. So they bind to the DNA, and if they cause more damage than the cell can repair, then the cell often dies. And that's great for tumors that are growing really quickly because it doesn't allow them to replicate, to change, but it can be a problem for dynamic cells that need to do things like neurons. And so the peripheral neuropathy that people develop when they're exposed to platins really depends on what agent it is. So there are different generations of these drugs. So the first and third generations, cisplatin and oxaliplatin, cause much more neuropathy than second generation drugs called carboplatin. So as an example, oxaliplatin will cause neuropathy in nearly 90% of the patients if they're given enough of it. And so I think about this a little bit like the field of dreams. If you build it, they will come. And if you give people enough oxaliplatin, they will probably develop neuropathy. And the reason it's important is that knowing that many people will develop it, it's important to monitor for it so you can adjust your treatments accordingly or treat the symptoms. So there's some things that are sort of unique about the neuropathies that develop with cisplatin specifically. So this tends to affect the large nerves, and nerves are composed of really two different components. There's an axon, which you can think about like the metal inside a wire, and then there's the insulation that's around it, which is called the myelin. So this can affect the large nerve fibers, and it usually does not affect the insulation around, but the nerve itself. And in affecting the large nerve fibers, it usually causes balance issues and loss of sensation, but doesn't necessarily cause as much pain as some of the other agents. It can cause symptoms in the hands and feet at the same time. And oxaliplatin, for instance, frequently causes coasting. So the development of the neuropathy or worsening of neuropathy after the chemotherapy is stopped within the first couple of months. There's an acute syndrome that's associated with this as well, called acute cold-induced dysesthesias. This can occur in up to 70% of people who get oxaliplatin, and the studies were usually in patients who have colon cancer. It tends to happen after the second or third cycle of chemotherapy, and it's usually in the hours after the infusion. So people describe distal or perioral paresthesias, so pins and needles in their fingers or around their mouth that's uncomfortable. Sometimes there's some throat pain associated with it, and people can get cramping or fasciculations, which are tiny movements in the muscle that aren't necessarily painful, but can be a little bit bothersome. But they typically go away after a couple of hours. The vinca alkaloids are another commonly used class of drugs. So these include vincristine, vinblastine, and there are a number of others as well. So these work also by inhibiting the assembly of microtubules and promoting the disassembly. So they interfere with the same mechanisms that we were talking about before. And there are a number of things about the neuropathy with the vinca alkaloids that make them atypical. So while almost all of these agents can cause neuropathy that affects the sensory nerves or the motor nerves, so sensation or strength, the vinca alkaloids are more likely than others to cause problems with weakness. So about 10% of people treated with these who develop neuropathy go on to have a little bit of weakness. It can affect the hands before the feet, and it can be quite painful. The other thing that's a little bit unusual about this is about a third of patients who develop neuropathy have what's called an autonomic neuropathy. So again, affecting those nerves that are dealing with their organs. The most common way that this is seen is with constipation, but it can happen with other things as well, like orthostatic hypotension, meaning people stand up from a seated position and their blood pressure drops and they get lightheaded. The other thing to be aware of if you're a practitioner is that this can cause some sort of unusual neuropathies. So it's been reported to cause cranial neuropathies, specifically third nerve palsies. So that would cause double vision. And it can also present as an acute neuropathy similar to Guillain-Barré. So a neuropathy that starts and escalates very quickly over the course of roughly 2 weeks. It involves both sensation and strength. So there are other agents that cause chemotherapy-induced neuropathy as well. Bortezomib and thalidomide, which mainly are used for multiple myeloma. Sorting out chemotherapy-induced neuropathy with these can be a little more complicated because the underlying diseases you're treating can also cause neuropathy. So it can make it a little more confusing. We'll talk about some of the hints and pitfalls to trying to make these diagnoses. So for bortezomib, it's a protease inhibitor. The mechanism of action of how it causes neuropathy is really unknown. But it very commonly causes neurotoxicity. About 85% of people that receive it develop some amount of chemotherapy-induced neuropathy. Unlike some of the other forms, the neuropathy from this tends to resolve fairly quickly as compared to others. And interestingly, the neuropathy with this can be demyelinating. So it can affect the insulation around the nerves rather than the nerve itself. And while that can cause pretty dramatic symptoms quickly, like a loss of strength or sensation, that insulation around the nerves and the myelin can actually be repaired by your body much faster than the nerves that are, than the wiring that's inside. So that's why the neuropathy improves more quickly. Thalidomide is a TNF-alpha inhibitor. About half of patients treated with this develop neuropathy, and those autonomic symptoms like constipation are more common in these patients as well. And then cytarabine and nelarabine, used for leukemia and lymphoma, rarely cause neuropathy, but they can cause a disabling Guillain-Barré type picture as well. So how do I know if I have it, if you're a patient, or if your patient has it, if you're a practitioner? So if it walks like a duck and it quacks like a duck, it's probably a duck. And the reason I say that is that most chemotherapy-induced neuropathy is really quite obvious to diagnose. Many patients diagnose it themselves and may tell their oncologist that they have it. And that really is because of the symptoms and the time course, both of which are fairly predictable. So we'll talk first about the symptoms. So I'm going to share with you some of the questions that I use with my patients to try to elicit whether they have numbness or whether they're developing chemotherapy-induced neuropathy. So it causes numbness for people, and that's described in a number of ways. So some people describe that as a pins and needles sensation. Some people can notice that they have burning or itching, or that they just can't feel things. They may describe that when they step into the shower, they can't feel hot water on their feet. They may say that they feel like they have rocks in their socks or they're walking on pebbles, and may choose certain shoes because they found that there's one pair of shoes or slippers that feel more comfortable. The symptoms almost always bother people more at night than they do during the day. And if somebody's complaining of symptoms in their feet that happen uniformly throughout the day, it's worth at least considering if it's neuropathy, because it's really classic for the symptoms to bother them worse at night. That's not because there's anything about neuropathy that actually makes it worse at night. It's because at nighttime, people are relaxed, you're lying in bed, your brain is relaxing, you're not checking your email and constantly on your phone, and your brain starts to pay attention to the discomfort that's coming from your feet. So it can also cause balance issues. And the questions I use to try to elicit this from patients is to find out if they have any difficulty walking on uneven ground, so like in a garden or across an unmowed lawn. If they need a light on at night to navigate to the bathroom when the lights are off. And if when they're in the shower and close their eyes to wash their hair, if they need to hold on to something. As it affects sensation, it can also affect dexterity. So this usually is described as difficulty with buttons or zippers, picking up coins from their pocket, or sort of manipulating small objects. It can cause weakness, and somebody might describe they have trouble, opening a jar or a bottle of soda, or that they're catching their toes on their socks or when they're trying to put their feet into their shoes. And those are really the signs of weakness. With autonomic symptoms, they're a little harder, and likely, especially if people are having other side effects from chemotherapy, people may or may not bring these up when you start to talk about neuropathy. So things to look for would be constipation, orthostasis. So again, when you stand up, you get lightheaded, and that usually passes after a minute or so. Sometimes people have what's called early satiety, meaning they eat a meal and haven't finished yet, but are starting to get full because their stomach isn't moving things around as well as it normally does. People can also have abnormal sweating in the way of excess sweating or reduced sweating. And I just want to take a moment to talk to the patients out there or prospective patients out there to encourage you to really have open conversations with your oncologist and your treatment team, whether it's your physical therapist, occupational therapist, et cetera, about symptoms that you're having. So one of my mentors in training who talks about his chemotherapy-induced neuropathy publicly is Ted Burns. He's a dear friend of mine and is a great mentor. And he developed chemotherapy-induced neuropathy. And together we wrote an editorial in Neurology a couple of years ago, which spoke to a number of things. But one of them was the fact that sometimes cancer patients are hesitant to share these symptoms with their oncologist because they're afraid that it might lead the oncologist to reduce the dose or even potentially to stop the chemotherapy. So I want to sort of make a plea to the patients out there to please be honest and upfront with your oncologist. They have your absolute best interests in mind. And these are conversations that we have. There aren't hard rules usually about what to do with chemotherapy, even if people are having side effects. So the next thing in terms of making the diagnosis is understanding the time course. And there are things that can make this a little more confusing, like if somebody has a pre-existing neuropathy, say from diabetes, or if they are developing neuropathy from their cancer, which can happen. But let's talk at first about sort of the generalities. So when we think about chemotherapy-induced neuropathy, this is kind of what people tend to think, that it happens somewhere in the middle of chemotherapy. It sort of hits maximum when people finish chemo. They have symptoms for a little while, and then it starts to improve. And I think if you look on average, this is probably pretty accurate, but there's a huge amount of variability. And it's important to understand that to be able to diagnose this appropriately. So there's some patients who just will never develop chemotherapy-induced neuropathy. We don't understand why some people are able to tolerate tremendous amounts of chemo and never develop neuropathy. So some patients will do that. Some patients will not have any earlier in their treatment, and then what they'll start to notice is maybe pins and needles or tingling that'll happen in their hands or toes somewhere, a little more than halfway through, and they'll develop symptoms for a couple of days after chemo, and then they sort of go back to their baseline. And this happens a couple of times over and over, and then when they get towards their end of their treatment, then they start to develop symptoms that stay a little longer. The next pattern would probably be people who follow the same pattern but have a worsening of the neuropathy. So they develop a neuropathy that's symptomatic, that's enough that it's affecting their quality of life. And then finally, there are also patients who develop a pretty substantial neuropathy very early on in the course of the disease. And we'll talk a little bit about this early on. And what's interesting and something we don't really understand about these patients is sometimes these patients develop a substantial neuropathy early on, but then it doesn't progress with ongoing chemo. There are patients, however, who, if you can continue to give them chemo, they will worsen as you go forward. So next, I want to make I made a plea to the patients. I want to make a plea now to the oncologists and the people that care for them. A very brief sensory examination can be really helpful in sort of tracking the course of chemotherapy-induced neuropathy. And I frankly don't think it's something that needs to be done at every visit. But if within the first couple visits, doing a really quick examination of somebody's sensation can be really useful. And that can be done very quickly in less than a minute or half a minute. So grab something that's cold in your examination room, touch it to their knee so they know what cold feels like, and then put it on their foot. And if the two feel different, kind of slowly drag it up their foot and see where it starts to feel cold again. You can do the same thing for the upper extremity. If you want to test more modalities, you could do it with something sharp, like a wooden Q-tip broken in half, and see if there's a difference, test in the same way. But even with just a very, very brief screening exam, you can get an idea if they have any neuropathy to begin with that they may not have symptoms from. And that may turn out to be useful information if they start to develop neuropathy down the road. It's also helpful to check people's reflexes if you have a reflex hammer. We know from some of our studies that patients will often start to have a depression of their reflexes before they have any other exam findings or before they start to have any symptoms. So in terms of a laboratory workup, there really isn't any clear consensus about what should be done to try to evaluate patients either for risk before they start getting chemo or if they develop chemotherapy-induced neuropathy. So I think if you talk to neuropathy experts, what they tell you is most of us probably do the screening examination that we would do in any other patient who developed neuropathy. And that's to look for sort of the basic things that we know cause neuropathy. So hemoglobin A1C to look for diabetes, potentially checking their lipids, looking at an SPEP to look for a monoclonal gammopathy, and then checking vitamin levels. I think this is of particular importance in patients undergoing chemo who have a lot of nausea or potentially don't have a great diet. Usually that's B12, but if you have patients who are, excessively nauseous, you may want to check other vitamins like B1 and B6 if they're really not eating well. I would suggest against checking a paraneoplastic panel, except in certain specific instances. If people are following a very clear course of what you expect for chemotherapy-induced neuropathy, paraneoplastic panel is probably excessive and unnecessary in addition to being expensive. There are paraneoplastic syndromes that cause sensory loss. So anti-HU that's usually with breast or Hodgkin's, or anti-CV2 with small cell lung cancer or thymoma. But typically those cause a very dramatic sensory neuropathy called a ganglionopathy when that's the case. So in terms of other things you can do, electrodiagnostics. So you may not want to tell my other neurologist friends who do electrodiagnostics this, and I do them as well. So this is an EMG or nerve conduction study. But I frankly don't think you need one in many of the patients. There certainly are circumstances where EMG nerve conduction studies can be very helpful. But again, if this is garden variety CIPN that doesn't have any atypical or alarming characteristics, I don't know that doing electrodiagnostics really makes an important difference. And for patients who've never seen these before, in EMG nerve conduction studies, basically a way to test how electricity moves in your nervous system. So we place a little recording electrode on one part of your arm, like down on your hand or foot, and then we stimulate the nerve using a tiny little zap of electricity that feels about like if somebody hit you with an elastic band. And we can watch the electricity go down the nerve, and by looking at the response, we can decide how much and what kind of damage has occurred. And then we do something similar with a very, very small needle that gets inserted into the muscle to look at the electrical activity. So there are cases where that can be really helpful. So if you have atypical cases where people are developing an asymmetric neuropathy, there's rapid progression, there's a substantial amount of weakness, if you're concerned that there may be another sort of etiology that's happening, these are times when it might be really important to get electrodiagnostics. The other setting is if somebody already has neuropathy and you're trying to decide how bad it is and what the risk may be moving forward, sometimes it's helpful to get a baseline to see what their neuropathy looks like. So skin biopsy is a way that we evaluate for small fiber neuropathy, so neuropathy in the sort of the tiniest nerves that are in the skin. I don't think that, frankly, it has a whole lot of utility in this setting. And then many patients will ask about monitoring, whether you need these electrical studies to be done on a repeated basis to understand what the nerves are doing. And I think the short answer is no. Most patients that have chemotherapy-induced neuropathy are very attuned to what's happening with their body, and simply asking them about their symptoms is sufficient to understand how bad their neuropathy is and whether it's progressing, and combined with an examination, that can give you a whole lot of information. So there are instances where maybe it quacks like a duck, but it might walk like a duck and it might not look like a duck, and you can't tell exactly what's going on. And for the oncologists in the crowd, I've just included this case to briefly talk about a couple important points. So let's imagine this is a neurologist. I have a 68-year-old who's referred to my clinic for gait imbalance. So I talked to the patient. They describe that they have a little bit of an unsteady gait, have some numbness down in their feet, but are not having a lot of pain, no major effect on their quality of life. I examine them, find that they have some exam findings that show that they have peripheral neuropathy, mainly with sensory loss, but normal strength. We do a workup with all the labs that we talked about, and they have an IgM kappa monoclonal gammopathy. We refer them to hematology. It just looks like MGUS, and the neuropathy isn't doing a whole lot. And this happens frequently, and so we sort of follow these patients. But now let's imagine it's 2 years later. The patient returns to our clinic now because they've been seeing their oncologist, been diagnosed with multiple myeloma, and they're on bortezomib. And they're experiencing a substantial progression of neuropathy. And as many of you know, something like multiple myeloma can have neuropathy associated with it. So when a patient is on a drug like bortezomib, frequently the question is the neuropathy from the disease itself, or is the neuropathy from the drug that we're giving to treat the disease? And this can be really tricky to figure out sometimes. So there are a number of things that we can do to try to sort this out. So these are kind of tips to help differentiate this. The first thing is, I think about this sort of like you do in real estate, where it's location, location, location. Trying to figure out a question like this, it's history, history, history. So what you need to do is drill down on all the specifics And for patients in the audience who have multiple myeloma or were treated with some of these chemotherapeutic agents or trying to figure out what's going on, you can really help out your oncologist by paying attention to these and carefully delineating your symptoms. So you want to start by gathering a history of what the neuropathy looked like very early on, how long it's been there, what the phenotype was like. So was it just numbness? Was there a lot of pain? How bad was it? You want to look to see if around the time of cancer diagnosis, there was any change in the severity or the phenotype. And then really with each cycle of chemotherapy, you want to see if the patient thinks there's a substantial worsening of their symptoms or some sort of change in the distribution of symptoms, like it climbed up their leg with the increasing dose. And really most of the time, if you do a very careful job of this, it can help you figure out which of the two it is. One of the things that can be tricky is that it sometimes can be hard to know based on the cause of the neuropathy what's going on. So for instance, if somebody has an anti-MAG antibodies and a neuropathy with them, it's very hard to treat that with drug. But with something like multiple myeloma, if they have neuropathy associated with it and they're getting effective treatment for the multiple myeloma, the neuropathy component will often go away or will improve. So you can use that data to try to decide what's going on. So for instance, if you have a patient with multiple myeloma and their disease is in excellent control on medication, but their neuropathy continues to progress, that's probably due to the chemotherapy, not due to the drug. The counter to that is, let's say you have a patient who's presenting early on and has sort of a relentless progression of their neuropathy despite the drug. That makes it a lot harder to tell whether it's from the ongoing disease or whether it's from the chemotherapy. And in instances like that, sometimes it's really helpful to briefly pause with treatment if it's safe and it's reasonable to do so, to see if the neuropathy stabilizes or starts to improve a little bit, because that will at least give you information about the underlying cause, and then you can decide what to do with that information afterwards. The other important thing to think about is that with some of these neuropathies, there are important exam findings that can help you decide whether it's from chemotherapy or from something else. So for instance, in somebody who has Waldenstrom's with an anti-MAG, they're often going to have ataxia and tremor when you examine them, which would be fairly atypical for a patient with chemotherapy-induced neuropathy to have tremor. Or if you have a patient with POEMs, you can look for extravascular overload, skin changes, hyperemia, increased VEGF levels, and those things can help you decide that maybe this patient with osteosclerotic myeloma actually has POEMs, and that you're not just seeing ongoing changes from their chemotherapy. In these settings where it's hard to figure things out, electrodiagnostics are very helpful because they can help find out if this is a demyelinating neuropathy, which you can see with things like multiple myeloma or Waldenstrom's or POEMs, or if it's an axonal neuropathy. Okay, so now I want to move on to kind of the second part of the talk. So we're going to talk about important questions, and there's two sorts of information that I included here. So one is sort of information for providers, but the second is some sort of hints about how I talk to patients about these specific components, because these questions come up over and over and over again. So one of the first questions is, can we predict CIPN using risk factors? And this has turned out to be something that's really tricky to figure out. And so there are kind of two columns in this table here, and I've put it as confirmed, and I'm using air quotes because there's a little bit of disagreement about this, and then things that are suspected. So on the confirmed side, these are things that multiple studies have shown that these likely increase your risk of developing chemotherapy-induced neuropathy. So if you have neuropathy before you start chemo, being older, or if you have what's called genetic polymorphism in a specific gene. So there's been research to show that, that in some patient populations, for instance, like in children with acute lymphoblastic leukemia, people noticed that there were some children getting treated with vincristine who were developing really substantial neuropathies while others did not. And what they found is there was a very small mutation in a gene that metabolizes vincristine. So basically it means that when you're giving these patients vincristine, it's like they're getting a higher dose because their body is not breaking it down normally. And so aside from a couple genetic mutations like this, which are really few and far between, those are really all of the kind of confirmed risk factors that we know about. There are a number of suspected risk factors, and these are based both on studies, but also on what we know about neuropathy, in that many of these things cause neuropathy in and of themselves. So if you follow the logic, it's probably likely that they increase your risk of developing chemotherapy-induced neuropathy. But I will say it's interesting when you look at the literature, even with large studies, there's disagreement about which of these things actually cause neuropathy and which of them don't. I will say we've done some of this research ourselves, which is soon to be published. So we looked at a cohort of over 500 patients that received paclitaxel mainly for breast cancer, and tried to see if we could figure out what the risk factors were for developing neuropathy by the end of chemotherapy, but also tried to figure out if we could see who would retain this neuropathy, so who would still be affected by it 2 years later. And so for the end of chemotherapy, what we found after looking at a lot of different risk factors is that pre-existing neuropathy is clearly a very big risk factor for developing worsening neuropathy when you're exposed to chemo. And that, interestingly, hyperlipidemia was too. But again, this is preliminary data, and we need to see if this is borne out in other studies. So at the 2-year mark, we found pre-existing neuropathy, not surprisingly diabetic neuropathy. So this may have something to do with people's predisposition to continue having neuropathy symptoms at 2 years after they finish their chemotherapy. And interestingly, hypertension, again, which I don't think has been found in other studies. So there's certainly more work to be done here. So can we prevent chemotherapy-induced neuropathy? This is like the holy grail of chemotherapy-induced neuropathy research. And I put up this slide that I made, I think 5 years ago, just to show that people have used a variety of different classes of drugs to see if we can prevent it, with varying results. And basically, there have been multiple reviews that have looked at all of this research. And in 2015, there was a consensus statement from ASCO that said, on the basis of the paucity of high quality, consistent evidence, there are no agents recommended for the prevention of chemotherapy-induced neuropathy, which frankly is kind of deflating. This is such a huge problem, and there's been so much time and money put into the research to try to prevent chemotherapy-induced neuropathy that I feel like this sort of took the wind out of people's sails a little bit. So the question is, have we come anywhere in the last 5 years? And I think the answer to that is sort of. So we're starting to make some progress. Interestingly, some of these things are medicines and some of them are not. So there's been a lot of interest in cryotherapy with or without compression. So as some of you probably know or have heard, with patients receiving specific kinds of chemotherapy, they wear cooling caps on their head to prevent alopecia or hair loss. This was recognized many years ago. This has been an effective strategy. And the suspected mechanism for why it works is probably twofold. One, when you cool down the skin, you reduce the amount of blood flow to that area. So you're reducing the amount of blood that goes through when there are very high levels of the chemotherapy in the blood. The second is that by cooling down the tissue, you're probably slowing down the metabolism that's happening in those cells. So there's not as much demand on them, and so potentially not as much injury happens to them. So people carry this forward and have done a number of studies cooling down people's arms and legs while they're getting chemo, so when they're in their infusions. So I think there have been roughly 6 trials that have looked at this, and there were very encouraging results out of Japan, which found it's almost 75% reduction in the loss of sensation and a 90% reduction in patient symptoms of pain. There have been multiple other studies that have been done to follow this up, and the findings have been much less robust in other studies that haven't found a difference or met their endpoints. But I think that there may still be something to be seen here, and there are ongoing studies now in the US and elsewhere that are examining this. There are also some cancer centers that have just started doing it empirically. Because there's likely to be very little harm associated with it. So some institutions are starting to do this. There is very exciting data about exercise. So this is based on a couple of studies, but one in particular, a large study of 600 patients that they randomized to 6 weeks of weekly walking or exercise resistance that they were doing during their course while they were getting chemotherapy, not while they were hooked up to the infusion, but in the weeks when they were getting their chemotherapy. And they've looked at analyses about halfway through this trial and found that there looks like there is less loss of sensation and less pain in these patients and a reduced intensity of both of those. So I think that's important. And there are ongoing studies here which are going to give us more data as well. And then in terms of drugs, for ganglioside monosalicylic acid or GM1, there have been a couple studies mainly out of China, one of which was retrospective, one of which was not blinded, and then one blinded study which has been performed that showed that there was potentially some benefit. So I think the jury is still out here. I think the next important question is will I recover? This is what patients want to know. So if we think about the time course, we talked about the different ways that chemotherapy-induced neuropathy develops. And one of the challenges when we're talking about it is that it can do a whole lot of different things after the chemotherapy stops. So if we look at an example of somebody who developed a substantial neuropathy, many patients will get better pretty quickly. Others may plateau for a while and then start to improve over the course of a couple of months. And I'd say this is probably the majority of patients with most of the types of chemotherapy. There are patients where it stabilizes and others where it actually gets worse. So there's a coasting phenomenon, which usually ends by 3 months after chemotherapy. But as you can imagine, if you extrapolate this out, for all the different possible endpoints, it becomes kind of hard to predict exactly what people are going to do. And so what I tell patients in general is that the vast majority of people who develop chemotherapy-induced neuropathy do improve, but sometimes it's hard to say exactly how much they're going to improve. Usually you start to see improvement within a couple of months, but the general consensus is that a lot of that recovery happens probably within a year, and there may be additional recovery up to 2 years. But that is sort of purely my observation. There's not good science behind that. So that's really been one of the important questions. What happens in the long run? It's great if we can cure cancer, but we certainly don't want people to have terrible neuropathy for a long time. So we've tried to get at this and to understand what the severity of neuropathy is after chemotherapy. This is that same study that I mentioned that we're going to be publishing. Again, preliminary data, but what this shows you is that on the left there, for people who develop neuropathy at the end of chemo, this is with taxanes for breast cancer. So about 70% of people actually developed some amount of neuropathy. So in about a third of patients, it was grade 1. This is by the NCI CTCAE criteria. So grade 1 neuropathy is very mild, probably does not have a substantial impact on their quality of life, and you're usually not on medications for it. About a third of patients will develop type 2 grade 2 neuropathy, in which patients do have substantial symptoms and sometimes are on medications for it. But really, it was a minority of patients that had severity much worse than that. And then 2 years out, at least with our data, half of the patients who were treated with chemo didn't have any neuropathy at all. About 20% were back at grade 1, so they had a little bit of sensory findings, but not a lot of symptoms. But it was around 15% who still had a substantial amount of neuropathy. And then from other people, because this was a retrospective study, there just wasn't enough data to say how bad their neuropathy was. So for the instances where people have started chemotherapy and they need to keep getting chemotherapy, it raises some important questions about how to address this and what to tell patients and providers about the risk of keeping the neuropathy. So this is a real challenge, and there's sort of 3 instances that I think of, or you can break it down into 3 categories. So the first is people who previously had chemotherapy-induced neuropathy. Years ago, they got agents for neuropathy, for cancer. They developed neuropathy, and then their neuropathy improved some, but now they have a recurrence of their cancer, and they need to get drugs that can be neurotoxic again. So what we know from the evidence is that getting multiple rounds of chemotherapy, or specifically getting different types of drugs, can lead to a cumulative neuropathy, so worsening of neuropathy. I think generally speaking, in my experience, if people developed neuropathy and then over the course of years it improves substantially and you need to give them the same agent, it seems like they may actually do okay. The corollary to that is if patients develop neuropathy the first time you treated them and it stayed as a pretty substantial neuropathy, I would certainly be concerned that if you give them the same or even an additional agent, they may have worsening of their neuropathy again. The second instance in which we think about this is people who develop neuropathy very early on, like after a round or 2 of chemotherapy. And sometimes with those patients, it's a challenge to decide what you're going to do with their drugs. And this is a situation where I think that electrical studies or electrodiagnostics can be very helpful. Sometimes patients have a little bit of sensory loss, but not a lot of pain. And you do the electrical study and you actually find out they have a pretty substantial neuropathy. That's important to know if you're going to continue giving them chemotherapy, because it really might suggest that that neuropathy is going to worsen. The reason I say that is there are other patients who have symptoms and even some mild exam findings. You do their studies and they're relatively normal, or they're normal. And in situations like that, we don't entirely understand what's happening, but it may be that there's sort of relative energetic failure of some of their neurons, but they haven't actually died, so they may recover well. So it's important to kind of understand, if you need to give somebody ongoing therapy, chemotherapy, what those nerves look like. The final instance where we deal with this is if somebody has a bad neuropathy already and they just need treatment if you want to make a dent in their cancer. And so these are the instances where I think it's really important to have a frank conversation between the patient and the physician about quality of life and understanding what is most important. And it's also important to talk to your oncologist about how the chemotherapy trials are done. There are some trials and some drugs where we understand that the exact dosage that's used or recommended, it's very important to use that to get the effect for cancer. There are others where we sort of have ranges, and it may be the case that giving a little bit less chemotherapy actually doesn't make a big difference in terms of overall survival. So that's an important thing to investigate with your oncologist. So treatment. And thinking about treatment, there are some sort of broad things to talk about, which I want to make sure that we address. So the first thing is that patients with chemotherapy-induced neuropathy and undergoing chemotherapy may have different goals than a patient who has neuropathy for another reason. And as patients, if you're in the audience, I would encourage you to really talk to your oncologist about this. And please, if you feel differently, write it in the chat, of course. But my experience in working with these patients is that they really want to know what their bodies are doing, whether their nerves are getting worse or whether they're healing. And if they're getting therapy, they want to understand if it's worsening them. So sometimes if people have mild or even moderate symptoms, they may decline therapy because they want to understand what's happening with their body. The other experience I've had, that are some patients that are just not interested in more medications because they already have a lot of drugs on board. They're already taking chemotherapy. They have other medicines they're taking for other reasons, so they're not interested in taking another drug. So it's important to work with your patients and to work with your oncologist to make sure you have an understanding of what you want in terms of treating the neuropathy. The other thing, as a provider, whether you're an oncologist, physical therapist, et cetera, I think it's really important to acknowledge patients' symptoms and to validate them, because there's such an important influence on quality of life here. I also think it's really important to empower your patients. So while we don't have drugs that fix chemotherapy-induced neuropathy, there's pretty good data suggesting that exercise may help recovery and or prevention. And I think it's really important because this gives patients an active role in the healing process, and it gives them some control over their bodies and over the disease process. So it may be appropriate to talk to them about that. And then you can obviously talk to people about what the different treatment strategies are. And it's important to delineate what the goals of therapy are. So these medications do not fix numbness. If your main complaint from chemotherapy-induced neuropathy is that your feet are numb, meaning you just can't feel hot water, none of these drugs or none of these therapies are going to do anything to fix that. But if there's discomfort that goes along with it, that's bothersome, or sensitivity that goes along with it, that's where these drugs can be really, really helpful. And I say that just because sometimes we'll see patients who've been put on drugs for symptoms that we might not expect to actually get better with the drugs. So in thinking about what the options are, certainly the very best evidence that we have is for duloxetine or Cymbalta. This is an antidepressant, but we use it for nerve pain, even if people have no depression at all. And I've had very good experiences with it because the side effect profile seems to be pretty good. People tolerate it well. Usually we start at 30 milligrams and increase to 60 after about 2 weeks. And you can go as high as 90, and infrequently we'll take people up to 120 milligrams. And so the best evidence is for that, but you can select other drugs depending on other things that you're trying to take care of or help the patient with. The tricyclic antidepressants are nice because they help people sleep at night. So if your patient is having a lot of trouble sleeping at night, you may think about prescribing nortriptyline or amitriptyline dosed at night, because it can be really helpful for that while it's also helping with the nerve pain. That's usually started in the range of 10 or 20 milligrams and titrated up to 50 or so, but you can certainly go higher than that if you're finding a benefit. Gabapentin is one that we've used for years for neuropathy. Because some patients complain of chemo brain or sort of effects on their cognition or their thinking, I personally try to steer clear of gabapentin some of the time because it can cause some of those side effects, but there's certainly plenty of patients who can't take antidepressants and for whom gabapentin is an excellent option. Pregabalin or Lyrica can also be used. It's similar to gabapentin. I find that it has a little bit more in the way of side effects, so I usually would prescribe gabapentin first. And then mexiletine is actually a cardiac drug that we've been using now in the neurology world to treat neuropathic pain with some benefit as well. And it's nice because it's a different class of drug if somebody's already on an antidepressant or sort of a gabapentinoid. Topical creams can be really helpful as well. So lidocaine cream to help numb the feet, or compounded creams that can be made at a pharmacy. If you're a patient here in Vermont, Vermont Family Pharmacy is the one that we typically use, because I don't know that there are a lot of compounding pharmacies here. And these usually have gabapentin, baclofen, sometimes ketamine, amitriptyline in them, and they can be really quite effective. But as you can imagine, they're good really for small areas. This isn't something you're going to rub over your entire leg. There are other therapies that have been found to be very helpful. Many of my patients benefit from acupuncture. Some prefer massage. Physical and occupational therapy have a very important role for patients who are having numbness, difficulty with dexterity or their balance, and mindfulness can be really helpful as well. I will say that the evidence or literature to support CBD or medical marijuana for treatment of nerve pain is not very good. There's not a lot of evidence behind it. However, some of these things are useful for some other side effects, like if you have a patient who's very nauseous or losing a lot of weight because they don't have an appetite. And if you're looking to these drugs to prescribe for those reasons, there are patients that find that they have a benefit from them for their nerve pain as well. So what's happening at UVM? So the Epiphania study is happening at UVM currently. This is a biomarker study to try to understand if there are things we can withdraw from people's serum, so neurofilament light chain, to give us an idea about who's going to develop neuropathy. So that study's been going on here for a while and continues to go on. Remote CIPN is a study that I submitted to the NIH earlier this year, which got a great score. So we're very hopeful that this is going to be funded. This is a study that actually looked at a new care model to take care of patients with CIPN, where patients would use an app to log their symptoms, and if they crossed certain thresholds, then they'd be contacted by somebody to help deal with their symptoms, sort of taking the oncologist out of the loop and letting nurse practitioners who have expertise in dealing with these nerve pain drugs to prescribe medicines. So we'll find out about that hopefully later in the fall. And then the other person doing chemotherapy-induced neuropathy research here is Dr. Michael Toth. And he looks not specifically at neuropathy, but on some of the effects of chemotherapy on muscle. And he looks specifically at in vitro and in vivo studies looking at exercise or electrical stimulation of the muscle, seeing if you can prevent the atrophy or the shrinking of the muscles that seems to happen with chemotherapy as well. If there are other people within our institution who are doing projects or are interested in projects, please let me know. I'm always interested in collaborating. We have a lot of people in neurology who are interested in this as well. So important things that I want to leave you with in terms of conclusions. So CIPN is common. It has important implications for cancer survivors and quality of life. So it's very important that we address it. As a patient, please be open and honest. Trust your oncologist's ability to understand what chemotherapy-induced neuropathy is doing in your life. And if the two of you are struggling together to treat symptoms, that's why we're here in neurology and we're happy to help. Know that most chemotherapy-induced neuropathy will improve over time. Even if we don't have drugs to fix it yet, the vast majority of patients do improve. And if you're a provider, really work with familiarizing yourself with some of these drugs to make sure that you can effectively treat CIPN. And we have a CIPN clinic over in neurology, so please feel free to refer your patients over there if you need help dealing with this. I just want to thank everybody who's helped make our CIPN group here work, specifically Kim Didis in the neurology and the oncology department, and Steve Addis have been a giant help to me. And all the oncologists here at UVM, it's been a pleasure working with all of you and collaborating with you. So thank you for your help. And if you have questions, we're going to move to a live question period now, where you can type them in the chat box. Thank you very much, everybody, for your attention.